Thanks for joining us today. This is our first webinar from the Healthcare and Pharmaceutical Management program at Columbia Business School. It came about because we have MDs who are also MBAs and wanted to hear directly from them what is going on, both from a clinical and then also from a business perspective. Today's moderator is Kush Modi, who is also an MD, MBA. He's getting his medical degree at Drexel while also pursuing his MBA at Columbia Business School. He is the incoming co-president of the HCIA, the Healthcare Industry Association, and so we're very lucky to have him. So over to you, Kush.
Awesome. Thanks so much, Bunny. I really appreciate it. And welcome everyone to today's webinar. It is my pleasure to be able to talk today with three current healthcare leaders that are working on the front lines as they address this pandemic that we're currently facing. So what I'll do to start, I just want to go over some of the ground rules for the webinar so everyone is kind of on the same page here. So first off, the agenda. So that was Bunny Ellerin giving kind of an intro to the HPM, and I'm going to go over a little bit of the overview of the event, do a short panel introduction, then allow the panelists to also introduce themselves. And then I will do a short, about 30 minutes moderated discussion with the panelists, and then we'll take Q&A from the audience afterwards. As far as the Q&A goes, please insert your questions in the question box to ask a question. We will be monitoring the question box. We will not be monitoring the chat box, so please do not direct your questions into the chat box. So to start, I'd just like to introduce our three panelists for today, starting with Dr. Langan. Dr. Langan is a board-certified emergency medicine physician and the current regional chief medical officer from Memorial Hermann in Houston, Texas, and specifically responsible for patient safety and quality. He is a graduate of Dartmouth College, Robert Wood Johnson Medical School, and completed his residency training at Mount Sinai Hospital in New York City. He graduated from Columbia Business School in 2009. Next, we have Dr. Morin, who is a board-certified plastic surgeon, craniofacial surgeon, and pediatric plastic surgeon. His private practice is located in both Manhattan and Hackensack, New Jersey, and he's affiliated with Lenox Hill Hospital and Hackensack Meridian Health. He obtained his MD from New York Medical College and completed a combined general surgery and plastic surgery residency program from Rutgers University and a fellowship in craniofacial and pediatric surgery at Miami Children's Hospital. He also has expertise working abroad through a nonprofit called Developing Faces and graduated from Columbia Business School in 2017. Lastly, we also have Dr. Isobel Rosenthal, who is a psychiatry resident at Mount Sinai Hospital in New York City, who is currently working on the Frontlines on a COVID-19 medicine team. She graduated from Yale University, at Columbia Business School, and Icahn School of Medicine at Mount Sinai. Isobel is interested in behavioral health technology, innovation in mental health, service delivery, and physician well-being. She worked with Town Hall Ventures, UCLA Health, Flair Capital, and is also interested in medical education, for which she's written for both the Washington Post and Mobile Health News. So without further ado, I'd like to start with Dr. Langan. If you could give a brief intro about your background, and then Dr. Morin, Dr. Rosenthal, that would be great. Thank you so much. Thank you so much.
No, thanks. That was a great job. So again, I've been out in Houston for 10 years, so moved right after the pretty much the financial crisis when I had finished my MBA. So I ran all the ERs for Memorial Hermann. It's about a $6 billion health system, largest system currently in Houston in the Southeast Texas area. And after running the ER, I switched over to chief medical officer role, and I've been in that for 5 years. So I'm still practicing. I still do two shifts, usually on Fridays and Sundays. So still seeing patients and full-time administration as well.
I'm Rob Morin. I'm a plastic surgeon, and prior to all of this, I did about half of what I did was cosmetic, and half of what I did was reconstructive. Ever since this started and all of the executive orders came down, 100% of what I do is reconstructive. And what I've been doing in the last 2 months is basically dealing with trauma patients in the emergency room, patients with severe facial trauma, facial bone fractures, and also patients with skin cancer. So, sort of the emergent and urgent aspects of plastic surgery. And it's given me sort of a unique insight into the inner workings of the hospital system and, basically the failures of the healthcare system in the United States and the world in general. I mean, we clearly weren't prepared for this. And I saw it from the front lines, from everything from the, PPE, mask policies and the evolution to now, this attempt to get back to normal without testing and without proper PPE. So, I mean, just from, the emergency rooms and the operating room perspective, I mean, it's been a wild ride, and I don't think it's, going to be resolved anytime soon.
Hi, I'm Isobel Rosenthal. I'm a psychiatry resident at Mount Sinai Hospital, but for the last month and looking into the future, I'm now a COVID-19 medicine resident, where I've been managing about 14 COVID patients every week that I'm on the floors. And so it's been a crazy, but time that I'm glad to be a part of. And
sounds great. Thank you all for the introduction. So I guess, I'd like to just start this off by asking kind of the most obvious question. Could all of you kind of tell me a little bit more about your experiences on the front lines battling this pandemic and what that's kind of been like? And what are some systematic challenges that have really been highlighted by, some of the things that you've been seeing? So maybe starting with Dr. Langan, since you have that dual role as both a physician and administrator, I'd love to kind of hear your thoughts on that as well.
Yeah, so we're a little bit more fortunate in Houston because we had a little bit more of a warning signs from the coast. There's a really quite a bit of fear because COVID-19 is not a disease that we learned about in medical school, right? We learned about coronavirus that causes a cold and a bronchitis usually. And so, we've had similar viruses like this in the past that have been contained overseas. And so this was really kind of a brand new disease for us. So there was a lot of fear, and also the messaging about what was safe and what was not safe was really kind of changing every day. And even with the CDC, saying everyone has to have an N95 for all contacts, and then they're like, well, it's probably droplets, so you need a surgical mask. And at the same time, you're hearing all these horror stories about so many people getting sick. So for me, fortunately in Houston, I talked to a lot of my friends back at Mount Sinai to see how they were doing. And, when I first talked to them, they're like, oh, it's been fine. We did 300 tests, 5 people were positive. And then the next week, the whole hospital was full. So, from that perspective, we really got in gear pretty quickly. So we're not designed to handle this amount of patients with negative pressure. So there's actually construction things that we had to do. We had to make negative pressure areas in the hospital, cohort like a whole floor that was going to become negative pressure as well. And then design an outside screening tent to make sure that, walking well wouldn't really, if we had patients that had COVID, that they're not going to be mingled with our other medical patients. The local government and authorities here did a good job about, closing everything down pretty quickly, because we closed down probably the same time that New York did. And we have the Houston Livestock and Rodeo. You may not have heard of it, but it's the most beer consumed in the world after Oktoberfest. So it's like a 20-day long festival in Houston, like 2.5 million people. And so we had it for a couple days, and then they decided just to shut it down, which was probably the smartest thing. We did have a cruise that came back, and those were our first cases. And we kind of identified them all over the city and started doing tracers of where they had been. And then they pretty much closed everything down. We were a little bit worried about, the equipment that we were going to have. But a few years back, we had that Ebola scare. So we had a huge stockpile of equipment that we never used that was sitting like in a closet that we found. So luckily we had, enough to get through that initial while we ordered more. And that was just a real nightmare. It's trying to get, everyone's trying to order the same mask, same equipment at the same time. And there's just like bidding wars. People are buying things on eBay, and there's kind of just that mass hysteria that ensues. So, yeah, from my perspective, we actually been doing okay just because we had that warning. But I really like to hear about what was happening in New York. I've heard a little bit, but yeah, one of my buddies, he's critical care at Elmhurst in Queens, and he had all of a sudden a shift where five young people came in sick, all getting intubated, and it's something that you're never really prepared for, right? And I think, obviously in hindsight, we should have taken more cues. Wuhan's a city of 11 million people. A virus is going to leak out of there. It's not like containing something, in West Africa, right? That's probably a little bit easier, containing something like Ebola. But it was inevitable that was going to come over here, and it came quickly.
Thank you so much, Dr. Langan. Dr. Rosenthal, now kind of, shifting to you, you've kind of been on the front lines of this. I'd love to kind of hear your thoughts, being a psychiatry resident, all of a sudden now having to shift to a medicine team, relearning some of the things that maybe you last saw while you were a medical student, and really trying to do the most that you can to address the pandemic. I'd love to hear your thoughts on this.
Yeah, no, it's funny because when Chris was talking, I remember getting the first email from Mount Sinai that said we had a patient who had tested positive for COVID-19 in early March. And then every day seeing emails with the number, at first doubling. There are a couple of patients under investigation. And then suddenly within a week, it was like, oh, there are 600 COVID-19 patients in the hospital. And it just kept growing and growing and growing. And I had never sort of experienced this feeling of like looking at these daily uploads and being like, oh my God, what's happening? From an off-service perspective, luckily I had done medicine months earlier in the year as a psychiatry intern. But obviously, going into my residency training, I never thought I'd be a frontline provider in a pandemic. So that's definitely, been a change. I think that one thing that has really struck me is that the teamwork that's going on within the hospital is just sort of incredible. People are being just really kind to each other, knowing what a horrible time it is. And for a lot of people doing their job in the hospital, it's sort of like the only social interaction that you're getting as people are self-isolating from their families, moving out of, their apartments with their kids to hotels. So it's been sort of an experience that none of us obviously could have predicted. And the feeling of being on the front line is something I could never have thought I would experience.
Thank you, Dr. Rosenthal. Dr. Morin, if you could speak a little bit to your role during the pandemic as well. I know you alluded to the fact that you're seeing trauma patients. Is this something new, or is it something that you kind of have been doing throughout your career? I'd love to hear kind of how things have shifted for you as a result of the pandemic as well.
So, as a craniofacial surgeon, I've been treating facial trauma patients for my entire career. The reason why it's interesting and it makes what I have to say sort of valuable is because I've been going to the emergency room for the last 2 months, and the evolution of what's been going on in the emergency room has just been totally mind-blowing. Chris, you made a comment about, sort of like getting the warning from New York, but New York and New Jersey should have gotten that warning from China. We all saw, pictures blasted all over the media of people in literal spacesuits, spacesuits, N95 respirators, goggles, hoods, just, duct tape, just total spacesuits. And then, my first interaction with the emergency room after all of this began, and with hospital administrators, throughout the entire state of New Jersey, was very adversarial, and to the point where, we as physicians were told that if we were caught wearing an N95 mask outside of a COVID positive patient's room, we would be fired or kicked out of the hospital. So, hospital administrators initially were putting all of the frontline healthcare workers in danger, sending us in without appropriate PPE. And, many people have compared this to Chernobyl. I mean, you guys have probably all seen the Chernobyl series, and, it was basically just rush in there and worry about the radiation later. In this case, it was rush in there and worry about the COVID later. And, what happened was many, many, many healthcare workers got sick, and a lot of them died. So, over the course of the 2 months, we saw a fairly rapid shift from you're not allowed to wear N95 masks in the emergency room outside of a COVID positive patient room to mandatory N95 masks and face shields for everyone, everywhere. And it's really unfortunate that, it wasn't the opposite. If you're dealing with a new pandemic and you don't know what's going on and you don't know the infectivity, if that's a word, err on the side of protecting people as opposed to erring on the side of, and we heard responses like, we don't want to scare the patients. We don't want you wearing an N95 mask because we don't want to scare the patients. I mean, that was just the wrong response. And, so the thing that I will never forget from this experience was sort of like the lack of preparation and the fact that we were told to rush in there without proper PPE initially, based on some crazy CDC guidance that said, like, you can wear a scarf. I mean, that's the thing that, like, I will never forget from this experience.
Yeah, absolutely. I mean, I think that in the news as well, numerous cases, people getting fired for wearing PPE that they bring in to the hospital on their own. So I really appreciate you kind of touching upon that, Dr. Morin. I think kind of going off of this theme of PPE, I'd love to hear, and I think, all three of you pretty much have mentioned at this point, I'd love to hear kind of your thoughts, Dr. Langan, from an administrator point of view. There has been increased tension. I think that there was tension between healthcare providers and administrators to start. And I think that this has just heightened a lot of those issues that kind of already existed. So I'd love to hear kind of if you have any insight to the thought process behind the whole PPE issue, as well as some of the other tensions that exist.
No, yeah. And so, when Robert was going over that story, they called me about a neurosurgeon that brought in his own N95. And they're like, well, you need to talk to him and get him to take it off. And, I gave him a call and he's like, I don't feel comfortable. I'm like, all right, keep your N95 on. That's fine. And he was in a case, it was kind of early on. And, but the thing was, it was making everyone else feel like they were unprotected. So from my perspective, it just was the same. It's like everyone needs to be protected properly and to the right amount. So it's a little bit different for me because, I'm an administrator, but then on Friday I'm down in the ER, right? So I'm actually seeing the patients and going in the rooms too. So I think they're a little bit more at ease that, I would wear an N95 and eye protection just for all patients because you didn't know who was positive. And we recommended that for, all the physicians that were on the front lines before we could get, an accurate feel of what was going on. And, we did do things like reuse the mask, which are normally it's not recommended, but we were going to run out if we didn't do that. And a ton of tension around that, and a lot of tension around the PAPRs, the personal respirators. So a lot of the ER docs, critical care docs wanted the full PAPR suit. So we went to order them, and they were available in August. So that's how long it was going to take because they were all gone. So what we did is we have PAPR suits for gas attacks, for like sarin gas and other disasters that could happen. So we made those available. And when they saw how heavy they were and like how cumbersome, everyone went with the N95 and the face shield. And what was a little bit reassuring too is, again, I'm calling back to New York and I'm saying, hey, has anybody gotten sick if they've had an N95 and a face shield on during intubation? And they're like, no, everybody's been okay. That's been protected. They said people got sick early on, especially in some of the patients actually didn't think that could be COVID positive, right? So they were not using that full PPE. Because of the PPE shortage, we actually sterilize the N95 masks also. So after the end of the shifts, we put them in a bin and they get sent down to our main mothership hospital, and they get put in a hydrogen peroxide vapor. A lot of the nurses were wearing makeup, so they would get ruined. So it was like 30% of the masks had to get thrown out because they had makeup on them. So then it was like a no makeup policy. So since then, that we've been okay, and it's just, we've had varying sizes of masks. Again, we were lucky that we planned for this like huge Ebola outbreak, so we had a lot of like hoods and suits and other things that we could wear. So I think had we not been prepared for that Ebola, we would really be in a lot of trouble. And now with the recycling process, it's been pretty good, and no real concerns. Actually, we're getting back to elective procedures this week, and have been in a pretty good state from that.
So I just want to go back to Dr. Morin one more time about the PPE. So one of the other concerns that I've heard recently is that a lot of times the EM doctors will have enough PPE for themselves in the EM within the ED, but then a lot of times when you have other specialists like yourself or OBGYNs, for instance, coming down to the ED, there might not be enough PPE to go around. Is that something that you've kind of noticed, and how have you kind of dealt with that and your colleagues as well?
I mean, so, personally, the story Chris just told with the neurosurgeon, and the whole point with Ebola, during the Ebola crisis, I actually ordered from my office a significant number of N95s. And so I had like a small reserve. So since day one, like I did not step foot into that hospital without an N95 mask on. And fortunately so, because I took patients to the operating room not knowing their COVID status and found out a day or two later that they were COVID positive. Like, that's an interesting phone call to get, the following day. Oh, by the way, your patient's COVID positive. Well, it's a good thing that I was wearing that N95 mask. But yeah, I mean, I was called in many times in the middle of the night. And to be honest, like if I didn't have the N95 mask, I wouldn't have known where to get one. They're all locked up. So yeah, I mean, I guess I could have asked somebody in the ER, but by that point, I'm already in the ER without an N95 mask. So, fortunately, I had a small reserve, but I don't know what people who didn't have their own supply did, because they were not readily available. They were locked in a cabinet somewhere, and I don't know who had the key.
Thank you for that. So I want to shift gears a little bit now and talk a little bit more about what's the kind of how things have evolved and what you kind of coming in the future. So Dr. Rosenthal, I'd love to hear your thoughts, being at the true center of this pandemic in New York City, how you've seen kind of things evolve and where you see them going over the summer, maybe talking about, do you think that there will be a second and third wave? And how long do you think we're going to stay in this socially distant environment?
Yeah, I wanted to just go back to the PPE question for a second, because I think I was really nervous when I was starting, because I had seen half of my colleagues basically test positive for COVID-19 in the world of wearing surgical masks. And since I joined, it's been the N95 policy, and I actually got my antibodies tested 2 days ago, because I haven't gotten sick with COVID. And I was convinced that I had to have antibodies because I couldn't believe that I'd been exposed so much and not gotten COVID. And I tested antibody negative yesterday, which I was disappointed about. But I think it also did make me feel better that the N95 and the Shield are doing something, especially because I've been in so many aerosolizing procedures. So that I can't believe this world in which the CDC was recommending surgical masks. Like, it's just so insane now in retrospect, especially when I've seen, colleagues who got really sick because they got such huge viral load exposure in the beginning. Sorry, but going back to your question. So in the 3 weeks that I've been on COVID-19, the amount of patients admitted to the hospital has decreased by 50%, which is obviously a good sign. The second wave of patients that I saw, in the last couple of days were also different than the patients I saw in the beginning. They were patients who had chronic illness, who were actually more in the hospital for their other medical problems and incidentally were found to be COVID positive, versus the patients I saw in the beginning who were very sick with COVID, requiring, high volumes of oxygen, a lot of them who had to be intubated, some who died. So that anecdotally, the population seems to be shifting. I am worried that the second social distancing stops, there will be a second peak, having been on service during the first surge. So it's hard to imagine that isn't going to happen without a vaccine, without many, with the large percentage of the population not being immune, not having antibodies, including a frontline provider who's had large exposure. So that's sort of what I see happening, is that there is going to be another peak as the measures start to fall off. And I can just hope that we do it slowly, because if all the social distancing measures are stopped, I think there's going to be a huge surge into the hospital system that the hospitals just can't deal with.
Sounds great. Thank you for that. Any additional thoughts kind of along those same lines from you, Dr. Morin?
Yeah, I think here is that we don't know what positive test mean. We don't know if there's immunity. We don't know if this is the test it's immune to, or at times no one has any idea. Is it echoing? Better?
Okay. Yeah, I think it's gonna.
So yeah, I think that's going to be the biggest issue going forward. Can we become immune to this thing? Is it seasonal? Does it change? Are we immune for a little while? Yeah, but I agree. If we don't, become immune and create herd immunity, then I would imagine there's going to be another peak once everybody starts relaxing the social distancing guidelines.
Thank you so much. So now I'd like to transition to make sure we have enough time for some of the questions from the audience as well. So first question is from Wally Hadik, and the question is, so first he just wants to say thank you. So we are hearing about virtual options and telehealth in medicine. I think he, as well as a lot of us, are curious to see how you think that telemedicine might change patient care. Is this just a temporizing measure until the cloud's clear, or is this truly a revolution in medicine? So maybe Dr. Langan, you could start, and then I'd love to hear from the other two panelists as well.
Yeah, sure. No, we've been talking about telehealth for a long time in the system and just never really got around to it. So when this hit, all of a sudden we've got the platform going, physicians enrolled, there was the interest. There were those docs that, weren't practicing in the hospital anymore and still wanted to see patients. So telehealth has become huge. A lot of even the specialists, orthopedists are following up on telehealth. My wife she's a psychiatrist. She trained at Bellevue, and she moved her practice exclusively to telehealth, and the patients have loved it. And a lot of our primary care is also moved to telehealth. So I kept pushing telehealth last year about, when are we going to do this? When are we going to do this? And I think this is going to, I think it will revolutionize telehealth, and it's become more accepted. There's been better billing codes and reimbursement for telehealth now, and I think that was an obstacle. And I feel now that, this has been so useful during this pandemic. I think the government and the insurers will also see that. And I think if the reimbursement is there, the physicians will go to that as a viable option. It's a lot more convenient for the patient. And especially patients you already know and you're doing follow-up on, very, very helpful. It's painful to call someone into the office just to give them results when you could do that over a telemedicine program. So I'm pretty excited to see where this goes, and hopefully it'll make the system more efficient and also help with things such as checking on patients once they've been discharged from the hospital and keeping them healthy and out of the acute care setting. So there's always some silver linings that come out of things like this. I think telehealth will be one of those.
Thank you, Dr. Langan. Dr. Rosenthal, I'd like to kind of get your thoughts on this as well. Is psych something that you've seen that's kind of grown considerably during this time? And where do you think that's kind of headed going into the future?
Yeah, no, I'm also excited about telehealth. And I think COVID-19 has revolutionized providers' ability to make the switch. For example, the VA system, which is notoriously slow, transitioned all of its providers at the Bronx VA to telepsych within 48 hours, which is insane. That in a normal time would have taken 2 years. So I feel very hopeful about that. And all of my colleagues who are not on inpatient psych units right now are all doing telepsych. Their patients like it. They like it. And so I feel excited about that.
Awesome. Thank you so much. Dr. Morin, any thoughts about how telehealth has potentially impacted your practice, or how you see it potentially tying into the future of plastic surgery?
Yeah, I mean, we integrated a telehealth platform, and I've been using it probably for the last 3 weeks now. And I've seen a significant number of both cosmetic and skincare patients through it. There are certain things in plastic surgery, obviously, that you can't do through a computer screen. I do a lot of rhinoplasty, so, I need to actually look inside of the nose. So, there's always going to need to be a preoperative meeting that's in person. But for that initial consultation, the patients, I think, have been enjoying the telehealth initial consultation. I certainly have, because it's interesting. We found that the entire thing is a bit more efficient. Somehow everything just goes a little bit quicker, and everything's just more efficient when it's done through telehealth. And I'm not exactly sure why. But yeah, I mean, we've been using it. I think everybody's been happy with it, and I don't see that changing, at least for the initial consultation, in the future.
It's great to hear. Thank you so much for your responses. The next question is from one of the current MD MBA students at Columbia, Andrew Luo. So he's wondering if, so now, I've been hearing a lot from friends of mine who are in New York City, where they're already starting to see people in Central Park having picnics, and, in Prospect Park, kind of hanging out with their friends and all these other things. As the weather starts to get nicer and people are going to be more and more motivated to go outside, how do you think we can continue to, as a healthcare provider, but as the general public in general, motivate the rest of the general public to continue some of these social distancing practices and preventative measures that we've started to take? Dr. Rosenthal, if you could start, and then Dr. Morin as well.
Yeah, so we talk about this all the time in the hospital, because for Mount Sinai, most windows look into Central Park. And so there'll be many days where I look into the park and I see all these people on blankets, having a picnic, facing the tents that Mount Sinai has pitched in the park full of COVID patients. And it feels really ironic at times but I understand the impulse. On my days off, I want to go into the park also. It's really hard to be cooped up inside. I am worried about the summer. I think that, people at least within the parks, they need to be wearing masks. And I get really frustrated because a lot of people aren't. And I don't think that NYPD has really been enforcing the mask policy. And I think that needs to be enforced. We know that helps stop the spread of virus if people are wearing masks. And that just seems to me like a thing that has to be done. And such an easy fix, because obviously being stuck in a small apartment all day in New York City is kind of impossible. So that's number one. I mean, I think number two is closing down some of the streets so that people can walk in the streets. There's less car traffic. I think this is the perfect time to experiment with closing down streets and what that looks like to create biking spaces and walking spaces can look like.
Thank you, Dr. Rosenthal. Dr. Morin, any thoughts as well along those lines?
Yeah, I mean, I think it's going to be a problem if people congregate in close spaces. I mean, fortunately, the weather is going to be nicer. I don't think these viruses tend to love the sun or hot weather. Fortunately, I think it's probably harder to transmit this when you're outside and kind of spaced a bit away from each other. But yeah, I mean, I definitely see this as a problem. I think the masking and the Purelling and the hand washing really needs to continue for the foreseeable future. But this is a bigger problem. The message about behavior sort of comes from the top. And when you have the president of the United States, saying I'm not going to wear a mask, and you have the vice president of the United States saying I'm going to, I think it was the Mayo Clinic. I know they have a mask policy, but you know what? I don't feel like wearing a mask either. I mean, when you have that kind of insane leadership, obviously there's going to be a disconnect between science and reality and what ends up happening on the streets of New York City.
Thank you. So I guess I'd like to shift gears a little bit again. So from the point of view of the general public, Dr. Langan, I'd love to hear your thoughts on this, considering that you're calling in from Texas right now, one of the states which is reopening. How should this question comes from Fabian. He's wondering if you have a parent who's healthy and you have children, do you send them back to school? How do you feel comfortable sending your children back to school? What are your thoughts along those lines, particularly coming from a state that is reopening?
Yeah, so I mean, obviously schools closed for the rest of the year. So it'll be interesting to see what happens in the fall. There's already rumors that schools in New York may still be closed. My daughter's actually in architecture school in Brooklyn, so. Yeah, if the kids are mingling, it's going to be really difficult to prevent that spread, and a lot of them are going to be asymptomatic carriers. So that's the scary part. I think they are going to have to do screening. So right now at the hospital, we come in, we have the temperature taken every day. They're probably going to have to do questions as well to see if anyone is actually sick in the house or if they've had any symptoms. But the scary thing about kids, again, is they can be a reservoir for the virus. And it may be difficult to prevent that. And again, I think we're going to be wearing masks until, right now, when I'm in my office alone, I take it off, but I have a mask that I have to wear throughout the hospital the rest of the day. I think all businesses are going to be like that, where there's going to be a lot of hand sanitizer and masks. And if you're doing face-to-face contact, we're going to be protecting each other from ourselves by using that mask. And I don't think that's going to stop until we get a vaccine, because I think this virus is going to be around.
Thank you. Dr. Rosenthal, the next question is for you. You mentioned earlier, this question comes from Isaiah. You mentioned earlier that you got an antibody test and that it came back negative. are you planning on getting another test? There's been a lot of talk in the news about the lack of specificity of these tests. So just curious to hear your thoughts on that. And then, yeah, that'd be great. Thank you.
Yeah, so at least the tests, and there, are a bunch of different tests. But my understanding of the test that I got was that it's right. It's not very specific, but it's highly sensitive. And so that there's been a lot of false negatives, but there haven't been a lot of false positives for the specific test that I got, which, if my antibodies had tested positive, then I would have felt confident I have antibodies. But exactly what Dr. Morin was talking about before, like, what does that really mean? Are people getting reinfected anyway? Can you still be infectious? We don't really know. But at this point, I'm not going to get tested again unless I develop symptoms and test positive for COVID-19. Then after that, I would probably get tested again.
Thank you, Dr. Rosenthal. Dr. Morin, I'd like to direct this next question to you. Given that you are a plastic surgeon, I'm curious to hear about what your thoughts are on elective cases and some of the challenges that you think we're going to face as we start to shift back to some of these types of surgeries.
So I've been involved in a bunch of phone calls with surgical societies and leadership and commissioners of health and all that stuff. And the bottom line is there are 4 things that sort of need to happen before elective surgery can resume in a relatively safe manner. The first is everybody wants to see a 14-day downward trend. So in number of cases, hospital admissions, deaths, stuff like that, there needs to be a 14-day downward trend. There also needs to be local hospital availability. So the hospitals can't be overwhelmed, because there's a risk of, anytime we do a surgical procedure, there's a risk of complications. Patients could end up requiring emergency room care or intensive care unit care, and we don't want to add to an overwhelmed and overburdened system. The third thing is there needs to be reliable testing, because you don't want, first of all, you don't want to operate on a COVID-19 positive patient, and second of all, you don't want to, expose, for the patient's safety, and you don't want to expose people in the operating room to COVID. And the final thing is there has to be an adequate supply of PPE. So we can't be using gowns and gloves and masks for elective procedures when they're needed to care for acutely ill patients. And then the final thing, which is sort of being talked about now, it's sort of the science of this disease and our understanding of it has changed drastically over these last 3 months. And now there seems to be a lot of talk about how this disease causes a hypercoagulable state, meaning tons of blood clots in the lungs, blood clots in the brain, blood clots in the fingers and toes. So one of the things that happens anytime you do surgery on someone is you increase their risk of some type of blood clot, either DVT, like deep vein thrombosis in the leg, and a PE, pulmonary embolism. So there are all these blood clot issues, in surgery in general. And now you have this disease, which is causing this hypercoagulable state and causing blood clots, all over the place. The combination of those 2 things sounds pretty dangerous. So that's something we have to look at too.
Thank you, Dr. Morin. The next question is from Dr. Thomas Bach. So I'd like to start with you, Dr. Langan. If you could talk a little bit about, being both a physician on the front lines and an administrator, how do you keep track of the best and really quickly evolving medical and therapeutic options that are available for patients? Are there policies that you put in place for your physicians? And do you have access to any investigational therapies? Would love to hear your thoughts kind of on all of these different subjects.
Yeah. So again, being a new disease, we really didn't know what was going to work, and our protocols have changed. As a lot of people may know, there was medication that was initially recommended, hydroxychloroquine and azithromax, and don't directly work on viruses, right? So these are all kind of medicines that have been tried, and then we found out that we were causing cardiac issues by combining those two medications. So we stopped that, and we're monitoring a lot of the data that is coming out and articles that are being published. There's actually a really good site called emcrit.org that one of my co-residents from Mount Sinai founded it, and he does a lot of podcasts, and he publishes all the latest evidence. So again, it's emcrit.org. So I actually been going to that and learning quite a bit from that. Gilead has a new drug out, the remdesivir. We did have that available for some patients. Then it was taken away because of just all the requests, and their data looks okay. It looks like it may be helping. And then one of the things we're doing is something called convalescent plasma. So we're taking the patients that have recovered, and we're seeing if they be candidates to donate plasma. And then we're in a study right now to see if that's working with our COVID-19 patients here. And I think it's going to keep continuing. There's a lot of companies that are doing well on the vaccine front. Moderna got a vaccine out pretty quickly, so hopefully we'll have some results back from that. J&J, there's a bunch of others that are also investigating that. So a lot of it's trial and error. The initial thought, too, was to intubate these patients early, and that proved to be wrong. It actually started causing a lot of lung injury, so we're trying to keep patients either on high-flow oxygen or devices that will help oxygenate their lungs without actually putting a breathing tube into the lungs. And that's also been helpful, that just the change in thinking. And it's been trial and error. And again, I do think New York has been leading everything with those studies. And a lot of it is us learning from places where they're really inundated with the patients. Luckily, so in Houston, we haven't had a ton of patients, but we've had our fair share, and we've had the resources to take care of them. So our outcomes have been pretty good. We haven't really had too many unexpected deaths. One of the things they mentioned about pulmonary embolism, we had one case that a patient ended up with PE after a long course of treatment, which we were really disappointed about, and it didn't end up doing well. But been more attuned to that also. And the past, I intubated a patient last weekend, and we're scanning the chest, and that guy had a PE as well. So yeah, there's still a lot more data out there, and we're really understanding all the safeguards we need to do for all these patients. So a lot's changing, and I'm sure a lot still will change.
Thank you, Dr. Langan. So Dr. Rosenthal, did you want to add something?
So at Mount Sinai, essentially for every patient who's admitted, you call infectious disease and you're like, hey, there are 10 different trials going on. Which trial does this patient qualify for? And exactly, the data for all of these trials is so variable. Even for remdesivir, which has promising data, they didn't have a control group in any of their studies, which is obviously a problem. A lot of studies are getting published ahead of time without peer review. So the data for a lot of these different methods is still pretty weak, but obviously because we don't have a treatment that works, we're still enrolling people for all these different clinical trials. And the one thing that we now have been pretty aggressively doing that Dr. Langan alluded to, and sort of Dr. Morin, is anticoagulation. We've been starting a lot of people on therapeutic anticoagulation, but we're also having to think about the risk of that as well, because now there have been some patients who had brain bleeds. So it's a fine line between these treatments.
Thank you, Dr. Rosenthal. So I'd actually, Dr. Rosenthal, I'd love to hear your thoughts. Next question here is from Jeff. He's wondering, what do you think that the psychological effects of treating COVID-19 patients for frontline providers will be now and into the future. And I'd kind of love to hear all of your thoughts on whether or not you think this will lead to even more of a doctor shortage and even more physician burnout than the extremely high rates that we've been seeing recently. So Dr. Rosenthal, if you could start, and then Dr. Morin and Dr. Langan as well. Thank you.
Yeah, I mean, I think that medicine will obviously be revolutionized by this. I think training in this, I think residents looking into the future will want more rights as physicians in practice because of, you know, the bodily harm that many residents have put themselves on the line for every day taking care of these COVID patients. I am worried about the long-term effects. I think every week that you go back in to take care of these really sick COVID patients on the wards and the ICUs, it does become more draining. And I think that's something that we need to start preparing for now. Mount Sinai has actually done a good job with this. They have these like mental health liaisons, which are like psychiatry teams for each unit on the medicine floors, and you can like call at any time. But I think it's very hard to like stop in the middle of your day and be like, oh, I'm stressed when you're managing a list of, 14 unstable patients. But I think we need to start preparing for how we can help providers when this is over. And obviously any support we can provide now matters as well.
Thank you so much. Dr. Morin, if you could talk a little bit about, from your point of view, seeing patients in the ED, seeing how physicians are reacting to the situation on the ground in, really the hotspot of the entire pandemic. How do you think this is going to impact the physician shortage? I know you talked about your own frustrations with the lack of PPE, the tensions between physicians and administrators. So I'd love to hear your thoughts on how you think this is going to kind of impact physicians moving forward.
So, I think this has made a pretty bad situation significantly worse. So another role I play is I sit on the board of directors of a 500 physician organization. It's called the New Jersey Doctor-Patient Alliance. And, we have somewhere between 400 and 500 physicians in the state of New Jersey who are members. And, we have an ongoing chat on WhatsApp, and there's another one for New York. So, it's just 24/7 constant chatter from physicians all over New York and New Jersey. And so, I can tell you with 100% certainty, physicians are very, very unhappy and very, very angry. We've always felt taken advantage of in the past, and we've always had an adversarial relationship, with insurance companies. And just as an aside, the one entity that is making out like absolute bandits in this era are insurance companies. They continue to collect premiums every single month, yet they haven't paid out an elective surgery claim in like weeks and weeks and weeks. If you want some stock advice, the health insurance companies are going to do unbelievably this year. That's an aside. Back to your question. Yeah, I think it's a big problem. It's obviously a big problem. I'm sure everybody heard in the news that an ER physician in New York, recently committed suicide. Physician unhappiness and physician suicide was a big problem, when we entered this, in January. It's only gotten bigger. Physicians are very unhappy and very angry. And, I hope this causes change. Like, we've never been allowed to band together. We've never been allowed to sort of form, do collective bargaining or like form unions. And, I think the time has come for that to change. Like, we need to unite, and we, need to fight for our common goals and rights. And, it's basic stuff. We want to be compensated fairly, and we want to be protected. Sending us into the emergency rooms without proper protection is just totally unacceptable.
Thank you so much, Dr. Morin. Dr. Langan, if you could kind of speak again. I know I've asked you to speak in this role multiple times today, but from an administrator standpoint, physician standpoint, would love to hear your thoughts on kind of how you reconcile these two roles and the discourse that's constantly kind of happening between the two.
I have no problem with Chris, by the way. I think Chris is a great job.
Yeah, no, it's a little bit rare. I mean, it was interesting from my perspective, having people that aren't going into the patient's room, telling the providers what to do. So, yeah, it's I'm all for it if they're gonna suit up and put a mask on as well. So, it's definitely a balance. There. Again, a lot of fear that we've had throughout this whole process. People were making out wills and other things like prior to starting to see these patients. But I think really it comes down to what's the scientific evidence, what's practical. And then also we do things that maybe are a little bit overkill. And for example, we started back elective surgery. We're testing every single patient that's coming in for elective surgery. The test is 70% sensitive, right? So it's not a great test if you're not having symptoms, but at least it's picking up a few patients here and there, and it's making it a little bit safer, and those elective cases are getting canceled. But again, it's a lot of effort we tested, I think the first day, probably over 200 patients, and we had 2 patients that tested positive. So we saved two people from coming in, but had to do a lot of effort to get that done. So again, I think a lot of it is looking at the evidence, being able to explain your decisions, and being able to reference things, and err on the side of caution if you don't know. I think that's one of the most important things. I think it's difficult. I think in New York's situation, again, it would be really tough to be administrator there, because you're making decisions and you don't actually have the resources to say, okay, everyone can wear an N95 because we're going to run out in 2 days and then no one's going to have one. And it is a little bit taking cues is huge from other areas. I wish we took more cues from what was going on in China. Or they had been a little bit more or forthcoming earlier on, and learning lessons from mistakes others have made. So, we again in Houston, we've been okay. I think we're still going to continue to see cases all summer, just because our curve has been flattened. But because it's flattened, you're just going to keep seeing patients, and just really have to remain safe. And everybody, from all the healthcare professionals to the citizens outside, have to, their focus every day is to make sure that they don't get COVID, and how they're going to protect themselves. And that's the only way we're going to get through this.
Thank you so much, Dr. Langan. So there's another question that came up here is, I think a lot of people are wondering what kind of the long-term, lesser-known effects of this disease will be. So I know that in the news you see a lot about, pneumonia and ventilators and things like that. But I'd love to hear your thoughts on, specifically chronic disease and maybe some diseases that require screening tests. It would be interesting to see, to hear kind of more about where you think that's headed, and how, give any words of advice for patients who might be struggling with this during this time. Dr. Morin, if you could start, and then Dr. Langan and Dr. Rosenthal afterwards, that would be great.
So do you mean long-term effects of COVID?
So long-term effects in terms of not COVID directly, but some of the lesser known effects of us being in a lockdown situation where people don't have as easy access to their physician.
So delaying other treatment.
Exactly. Yep. Exactly.
Yeah, I mean, so as it relates to me directly, I actually had a telemedicine consultation with a patient who has a squamous cell skin cancer on his cheek yesterday. And generally what we do is a Mohs dermatologist will take it off, and then I'll do some sort of reconstruction to reconstruct whatever hole they create. And the patient was telling me he couldn't find a Mohs dermatologist who was willing to do Mohs surgery to get rid of the skin cancer, anywhere in northern New Jersey. So yeah, I mean, there's certainly a backlog. There's going to be a delay in diagnosis of things. There's going to be a delay in treatment of things. I mean, there's certainly a delay or a lack in, chronic medical condition care like diabetes and stuff like that. So I mean, yeah, 100%. I mean, that's going to be a big problem for sure.
Thank you so much. Dr. Langan, Dr. Rosenthal, any thoughts on that?
Yeah, no, I mean, some of the patients that I'm seeing in the ER now are patients that really neglected themselves. I had a gentleman that had a little bit of renal insufficiency, so it wasn't in renal failure, but didn't want to go to the doctor. He ended up crashing his car and going into ventricular fibrillation arrest because his potassium went really high. And then we have other patients that are coming in diabetic ketoacidosis because, they're starting to have symptoms of diabetes, but they put it off for a month and now they're coming in. It's probably going to be a bit before people are even trusting of going into healthcare facilities, because everyone right now thinks if they go in, they're going to get exposed to COVID. So I think we'll see a little bit more problems with the management of chronic disease. And I really think that's where I hope telemedicine will come in a little bit too, because obviously people are going to be much more comfortable on a telemedicine platform than going and waiting in a waiting room with other people that may be sick. So yeah, a lot of it remains to be seen.
Thank you, Dr. Langan. Dr. Rosenthal, any thoughts along those lines as well?
Yeah, I mean, I guess for me, the population I think about the most are patients who have serious mental illness or patients with substance use disorder. And I think there definitely are like a lot of very sick psychiatric patients at home who aren't necessarily getting the care that they need, who are having trouble getting like their long-term antipsychotic injectables. In terms of substance abuse, I think what's been good is that some of the laws around like methadone clinics have become looser. Like patients now can get a 30-day supply of methadone versus having to just go in every day and get your methadone, which may end up actually being a better system. But a lot of those patients also rely on like groups, which have been largely canceled or virtual, which in those settings sometimes don't work as well. So I am worried what that population is going to look like when this is over and when we can really take stock of how it affected them.
Yeah, I totally agree with Robert. The people making out right now are the big health insurers because, when we decided to close down all our elective cases, our hospital, the census went from, close to 90 to 100% down to 40%. So yeah, there's not a lot of people out there getting medical care right now. It's a very, very, very interesting time.
Thank you so much. So before as we head into the kind of the end of this webinar, I'd love to hear from all three of you, maybe starting with Dr. Morin, and then Dr. Rosenthal, and then Dr. Langan to close. Are there any recommendations that you have for everyone out there, regarding how to stay healthy, both physically, mentally, moving forward, and then any closing thoughts as well from your end? Thank you.
Yeah, I mean, I would say one of the best things that has happened, at least to me in the last 2 months, is I've been able to go to the gym like literally 4 times a week. So, I mean, whereas I struggled to get to the gym like once a week prior to this, I mean, I'm running 3 times a day, and I mean 3 times a week, and I'm going to, a home gym, obviously not to like Equinox. So I think this whole thing really points out, obviously there are outliers and exceptions, but it seems that the unhealthy people who have many different coexisting diseases and obesity and high blood pressure and diabetes and, tend to not do as well. And smokers, another, if you needed another excuse to quit smoking, here you go. So, I think from like a personal perspective, like what you can do. I mean, I would exercise as much as you possibly can. Diet. Read the book How Not to Die. Diet is so important in terms of like overall health. Obviously, smoking would be just like a crazy thing to do right now. I've never really believed in vitamins personally, but I can tell you, I've been taking a multivitamin, a ton of vitamin C, a ton of vitamin D, and a reasonable amount of zinc. So, just again, there's a lot. I think the hand washing and the Purell, and if you're in a high risk situation, the N95 mask. I'm happy to hear that the N95 mask and the face shield seems to be working. That's fantastic. But just everyday people, just Purell. I would use Purell, 100 times a day if you're out touching like high contact surfaces.
Thank you, Dr. Morin. Dr. Rosenthal, some final closing thoughts. Thanks.
Yeah, no, thank you so much for hosting this. And it's been really nice to be able to talk about this and therapeutic for me. I think it's so hard when people leave the hospital. It's like, what do you tell them? I think just continuing, if you ever question that, should I go hang out with this group of friends in the park? Maybe that's not the right idea. If you have to think about it, don't do it. And I think, moving forward to the summer, I just am hopeful that obviously national leadership has hugely failed in this pandemic. I'm hoping that local leadership will continue to step up, especially in places like New York. And so, I remain hopeful that there will be an end, whether it's in 2 months, in 6 months, I don't know. No one does at this point, but I think that's a helpful thing to think about for a lot of people who are finding it very hard to stay at home. Like, this will not be forever. And I think that's been a helpful thing to tell myself, to tell patients. And that's kind of all you can do at this point is, be safe, and try to help out when you can.
Thank you, Dr. Rosenthal. Dr. Langan, any final thoughts?
Yeah, again, thanks for hosting. And I totally agree with everything that's been said so far, especially, the Purell. I'm not a big vitamin taker. I started taking vitamins before going into work. There may be some effective vitamin C. It's not going to hurt, so may as well do that. And, one of the biggest things is we're homeschooling 4 kids now. So I have a daughter who's doing architecture projects. She's a freshman in college all the way down to my son who's in junior high. My wife's doing telepsychiatry from home. And then they're loving it. I think they're just loving spending time together. I've reached out more to my brothers and sisters, talk to my mom all the time, check in on people. So yeah, take this opportunity to, although we can't go out and get together, just be more social, reconnect. That does a lot for your well-being as well, and your outlook. And everybody's going through this, so it's really important to share your experiences, especially with those people that you love.
Thank you so much, Dr. Langan. On a personal standpoint, as an MD-MBA student, one thing that has really stood out to me during this pandemic has been the unrelenting commitment that physicians have demonstrated to their patients through all of the challenges and frustrations, a lot of which you've outlined today. I've seen phenomenal physician leadership that has been all over the news and in mediums like this, and has truly been inspiring. And personally, I've never felt more sure of my decision to want to pursue a career in medicine. So thank you all for your dedication to your patients. Thank you for your time here today. I'd also like to thank Columbia Business School and the Healthcare and Pharmaceutical Management Program, specifically Bunny Ellerin and Bianca Bellino, for helping us organize today's events. And Bunny, now I'll pass it over to you. Thanks.
All right. Well, thank you, doctors, all of you. I feel like we're in grand rounds, all this doctor stuff. But this was so incredibly valuable. And just thank you very much for everything all of you are doing. It makes me very proud to know all of you. So have a great day, rest of the day, and I will be washing my hands a lot and using. Okay, Rob. All right, and everybody, we'll see you soon.
Bye, thanks.
Oh, and thanks, Kush. You did a fabulous job. Columbia Business School all the way.
Funny.